So what I want to do is utilize the opportunity to overlay some commentary on a demonstration I've provided. So we have a previously recorded demonstration, and what I want to do is provide some commentary on it as a general way to look at assessment and what you are assessing from the point of observation that you are occupying. So in the case of osteopathic manual therapy or any other hands-on therapy, you're on the outside of the body and you are observing things from that perspective. You're not necessarily directly observing internal processes. You may be observing things that can be interpreted as proxies for internal processes, but it's not completely accurate. So what we're going to use here as an example is testing of the neck, right? Now I say the neck because from the outside, you are going to have a hard time accurately dissociating soft tissue from hard tissue and what the heck is actually going on internally, whether it's a neurological holding pattern or maybe like neurological dysfunction, soft tissue dysfunction. But there are ways in which you can increase your confidence that it might be one of those things or the others. So what we'll do is just show you some stuff, just some very, very basic cervical assessment to make commentary. So I'm going to go ahead and let this play for a moment. So initially what you'll see is just very, very gently raising the head and taking a hold. Now, one of the things that you want to pay attention to is the hands down the side of the neck. Now, you don't want to squish the patient's ears, but you see the hands down the side of the neck. So what you're going to do is support the head with your hands, with both hands, so that the patient can be relatively at ease. They don't necessarily need to fight you. Now, the hands going further down the neck does two things. It increases contact, which means it increases control, thus reducing the possibility of uncontrolled motion. It also provides more sensory feedback to the practitioner. So the more of something you're in contact with, the more you control it and the more you can sense it. So that's a very, very basic thing there. So we just want to touch on that. If you're paying attention to a very, very specific spot and say your fingertips are on that very specific spot, then one of the things that occurs is that other parts are uncontrolled away from that. So you want to understand that you can get good sense from your hands, broadly speaking, especially when doing macro tests. And you use the concept that macro identifies micro, or large motions identify smaller problems within those motions. Or maybe a better way to say it, large motions are made of smaller subcomponents, such that if the large motion isn't working properly, the smaller subcomponent is identifiable, and usually with vision, you can usually see it. Now, we're just going to go ahead and look at just general cervical rotation. So I'll pause a good example of cervical rotation. And to keep clear, this angle isn't perfect, so you won't necessarily see the preference of motion. You might be able to notice it, but you just want to see that essentially, if you consider the neck as a straight line, the rotation is about that straight line. Or if you think about movement in the transverse axis, the transverse plane, you have the vertical axis. So you can consider the bony structure the vertical axis. So everything's going to move around that. All right, so you'll see this turning to the left, or rotating to the left, and then rotating to the right. All right, so you see that. Now we just go in and show you what it looks like when it's bad. Okay, so the patient's chin goes over their shoulder, their neck goes off that vertical axis. So this is a problem. This is something you don't want to do, because then you're not necessarily getting clear information about rotation. If you test this way consistently, you will have the ability to develop an understanding of what you find consistently. So internal consistency is the most important thing for any individual practitioner. But keep in mind that this is not necessarily testing rotation. This is testing a mix of planes. So your ability to understand where something is rotating versus where it's not is poor. Now, the other thing that I'll say about cervical rotation is that resistance in cervical rotation is a mixed message anyways. You're not necessarily identifying specifically the bones that aren't rotating as you would want them to. Often what you're really running into is soft tissue restriction in rotation. And if you test rotation specifically and side bending specifically, you'll often find it doesn't match the Fryette model. You will find a rotational preference in one direction in the cervical column and a side bending preference in the opposite direction, which is not predicted by the Fryette model. So just keep in mind that experientially, cervical rotation seems to be a mixed bag. If you're very intently palpating on bony structures within the cervical column, you can make the claim that you're identifying restriction to rotation. But what I found, broadly speaking, is that you get mixed messages. You find the problem with cervical rotation, you don't necessarily find it as the bone or the soft tissue because you seem to get mixed messages. So again, this is just bad cervical rotation. But as I noted, if you do the same type of test over and over and over and over, you're consistent with how you do it, you'll find something, you'll find restriction to the motion and you'll develop a way to deal with it. But you can't make the claim that you're testing rotation if the patient's going off axis. So you keep in mind with rotation, you've got that vertical axis for movement in the transverse plane is well represented by the vertebral column. So then we go to side bending. So what I want you to see here is the side bending itself. You have to pick a relatively arbitrary spot as an anterior to posterior axis or posterior to anterior axis to move about. Now, each one of these vertebral joints or intervertebral joints is going to have their own essentially axis of side bending or axis of movement in the coronal plane or the frontal plane. But what you want to do is essentially, if you think about it, you want to generate the letter C in the neck. So you're going to have to theoretically put this axis somewhere in the middle of the neck. You're looking for the letter C to occur. So when you do that, you're going to identify, it seems, more restriction that points to a more obvious level in the bony structure, but it wouldn't occur without some form of disruption to the soft tissue. So again, you get a mixed message. You can make the claim that cervical side bending on a hypothetical anterior to posterior, posterior to anterior axis within the vertebral column itself or within the cervical column will let you know where the restriction is more on the bony level, but you're still dealing with the soft tissues because your environment of observation is outside of the patient. So you have to keep that in mind. So we see this. You can see even from this angle that you've got that C shape occurring in the neck. And we'll compare that to essentially what I would call a windshield wiper through the whole neck. And what that means is that you're not necessarily side bending the cervical column, you're side bending the whole thing, or you're not side bending within the cervical column, you're side bending the whole column on top of the thoracic column. And I'll show you what that looks like here. So if you look at it, you see it looks like a windshield wiper. There's no letter C. You're just taking his ear to his shoulder, and there's no real obvious collapse in the column itself, in the cervical column. So what you would likely get from that, again, if you are internally consistent and if you do that more windshield wiper kind of deal, as opposed to the letter C within the cervical column, you're probably going to get really consistent information about those soft tissues that span from the shoulder girdle through the cervical region. Whereas if it's more in the letter C, you're going to get information that's a little bit more clear about the soft tissues that are more so intracervical. So this isn't perfect because some of those, say like levator scap, is going to be connecting on multiple cervical vertebrae, whereas say the trapezius is connecting to the nuchal line, but also the occiput. So the ability to really pick this apart is unclear. But broadly speaking, if you windshield wiper the column, then you're going to get some more understanding of what's going on between the shoulder girdle and the neck and the head. Whereas if you generate the letter C in your side bending of the cervical column, you get a little bit more information about restrictions that could be claimed intracervical. Now, keeping in mind again that we will reiterate these claims and these interpretations are not as clear as we would like them. So to make a very strong claim and say, oh, this is an intracervical lesion, or this is a shoulder girdle cervical restriction, it's not going to work out as well. But what you're going to do, however you test, now you can use all of the tests that we showed you and identify where the restriction is within those tests. If you use them all, you will develop strategies to interface with your finding over time that get sharper and more accurate. However, if you choose one of those tests and say it's the best test and it tests perfectly, then you're missing the problem of observation. The environment of observation is external to the patient. You're getting proxies for what's going on, not necessarily direct, clear, unquestionable information about what's going on. So what that tells us with respect, or what we can abstract to other testing in other areas, is that the test itself is specific to whatever it's testing. Sometimes it's clear, sometimes it's unclear, because the human body is a complicated thing, and there's multiple structures at play in all movements, which is why I tend to pull back to the concept of macro identifies micro, or large motions are made of smaller subcomponents. And when the large motion isn't moving as intended, the smaller subcomponents are usually visible, not perfectly, but usually. And then if you consistently perform the test in a consistent way, so you're internally consistent to yourself, you'll develop strategies to interface with your findings and to help the patient. But to make the claim that it's the best test would take a lot more investigation and agreement, which as it stands within hands-on healthcare, we don't really seem to have. One of the problems that, or one of the ways that you can identify this is if you simply look at things such as orthopedic testing. Orthopedic testing is considered a decent first step in as to where to look further, or where to essentially use more diagnostic processes such as images of varying forms. The orthopedic test isn't considered confirmatory or as accurate as you would want. It's just a first step. So you perform an orthopedic test, you have a positive finding, then you do more diagnostics with more technology that can observe in a way that a human working from the outside of the body can't. It's a great first step, but it's not as accurate as you would want it to be. So that said, any hands-on testing would suffer from the same problem. The environment of observation is outside the patient. Therefore, any findings that you have are proxies for what's going on in places you can't see, but they're not as accurate as you would prefer them to be. So this discussion with this example gives you the opportunity to understand some of those challenges, and then keeping in mind internal consistency is extremely important. So just to kind of refresh with respect to the cervical column itself, rotation, right, in the transverse plane about the vertical axis, as well represented by the vertebral column, as long as you keep it straight and don't bring it into the movement into the coronal plane, you're going to get good information about rotation. Maybe not necessarily, quote unquote, the bony diagnosis or the soft tissue diagnosis. You'll get information about rotation, and you'll identify where within that movement that the problem is, especially when you have good contact, because you're spanning the majority of the neck. When you are going to test side bending, you have to differentiate to some degree between intracervical side bending, which the cervical column will look like the letter C, and then side bending the entire cervical column on top of the thoracic column, which looks more like a windshield wiper. And then we can make the claim that that might give you more information about what's going on between the shoulder girdle and the neck in a slightly more clear way, whereas the, creating the letter C or the intracervical side bending will give you a little bit more information about what's going on in there, with some of the soft tissues that would be more constrained to that, so such as the scalenes and some of the smaller reflexive muscles within the cervical column. And you can attempt to make that claim, but I will say that they're all messy, right? So some give you a little bit more ability to claim one thing versus others, but they're all messy. So hopefully that gives you some insight, and we'll talk to you soon.